Hello guys. So now moving on to the next chapter of head, neck and face, that is endocrinology. The reason why we are studying endocrinology here with head, neck and face is, you all know that, right? The master gland for all the endocrinological organs, that is hypothalamus and the pituitary, right? So it is in the head, neck and face, right? In the cranium, right? So that is why, so to make justice for hypothalamus and pituitary, so the master glands, so let us consider all the endocrinological organs will be controlled by these things only, right? So that is why we'll finish off endocrinology here itself. Okay, now starting with endocrinology, so we'll discuss each organ, its functions and the pathologies with respect to that particular endocrinological organs. Okay, so starting with the master organ, that is pituitary. Okay, so pituitary with respect to embryological origin, so it is developed in the Rathke's pouch. Okay, so it is by the oral ectoderm, so Rathke's pouch. Okay, is where the pituitary gland will develop from. Okay, so you all know that, right? It is in the sella turcica. Okay, in the anterior cranial fossa. Suppose this is the cranium, this is the Rathke's pouch. Okay, so this is the Rathke's pouch. Here is where the pituitary gland is situated in. It is connected to the hypothalamus. Okay, so this is how pituitary gland will be there. So there are parts of pituitary gland, that is anterior zone, intermediate zone and the posterior lobe. Okay, so these are the lobes of pituitary gland. Anterior lobe, we all know that, right? All the hormones will be secreted by the anterior lobe, whereas posterior lobe, it is going to be ADH and the oxytocin. Okay, so oxytocin are the two hormones that is secreted by the posterior, whereas all the other will be anterior. Remember, there is something called as acidophils and basophils. Okay, so the difference is the twin organs, that is growth hormone and the prolactin are called twin organs because they are acidophils. Okay, whereas all the other hormones will be basophils. Okay, basophilic and acidophilic hormones. So basically this is acidophils. Then coming to intermediate, there is also an intermediate zone between posterior and anterior lobe. It releases melanotropin. Okay, melanotropin, why do we need melanotropin is for circadian rhythm, right? So that is when the melanotropin comes in. Okay, so now how does the posterior see, we all know that anterior pituitary gets its signal from releasing hormone, right? Releasing hormone will send its signal from the hypothalamus and stimulates anterior pituitary gland, which will send the particular stimulating hormone to that particular gland. For example, thyroid. Okay, so let us take adrenal gland. So adrenal gland will send the corticotropin releasing hormone to pituitary from hypothalamus, and then this will come and stimulate pituitary, and pituitary will start releasing the ACTH, right? Adrenocorticotropic hormone. Now once the adrenocorticotropin hormone reaches the adrenal gland, then the adrenal particular hormones will start releasing. So this is the function of hypothalamo pituitary axis. Okay, so this is how hypothalamus and pituitary works, whereas in posterior it is going to be different because it is the neuron that is connected. Okay, so it is going to be the neuron that is connected to the posterior pituitary lobe. Okay, so the thing is, the nucleus in the supraoptic and paraventricular nucleus of the hypothalamus. I told you, right, in neurology, there are many nucleus with respect to hypothalamus. Okay, so it is a three-dimensional structure only. All the images that we see will be a two-dimensional structure, right? No, it is actually a three-dimensional structure where many nucleuses will be present. Okay, so all these nucleus, what what it does is, basically has a certain particular function. Here the particular nucleuses, that is supraoptic and the paraventricular, will send the signal to the posterior lobe of the pituitary and will generate antidiuretic hormone and the oxytocin whenever it is required. Okay, so this is the function with respect to a posterior pituitary. Okay, so before we dive into all the specifics of the pathologies, so one thing I want you guys to remember is the with respect to endocrinology is that primary, wherever we see primary, means it means the gland. Okay, that particular gland. So suppose if it is a primary hyperthyroidism, secondary hyperthyroidism, in that way. Okay, so if it is primary hyperthyroidism that we are talking about, it means the gland that is what is involved. Okay, so this is what it means. Okay, then coming to secondary means everything else. Okay, so for example, it might be the pituitary gland that is dysfunctioning, and that is what is causing the pathogenesis of hyperthyroidism in that way, or sometimes it might be the external factor that is causing the gland to dysfunction in that way. So that is secondary. If the gland itself is affected, so it is going to be primary. Okay, so that is the main thing before we dive into pathologies. Okay, pathologies of all the organs. Okay, now coming to the first hormone that we'll discuss with respect to pituitary gland is growth hormone. Okay, so the only two hormones are very important with respect to pituitary gland pathologies, that is growth hormone and prolactin. Okay, so growth hormone, let us see how it acts. Okay, so growth hormone is released from the hypothalamus. Okay, I mean, meaning growth hormone, releasing hormone, I told you, right? Releasing hormone will be released from the hypothalamus. What it does is it stimulates the growth hormone release from the pituitary. Okay, now once the growth hormone is released, it will go to liver, and there it is converted into insulin like growth factor. Okay, so growth hormone also directly can go and act on the bones and all, but most of it will go to liver and be converted into insulin like growth factor, and then it will go to tissue and cause the action. What is the main action of growth hormone? To increase the growth, that's it. Okay, so this is the main physiology behind growth hormone. So the important point I want you guys to note it down here is, so from as the hypothalamus to release stimulates pituitary, somatostatin, there is something called somatostatin which will inhibit the growth hormone releasing hormone to stimulate the growth hormone. Okay, so that is the target. Okay, so if needed, we'll discuss about where it is needed. So remember, this is where it is targeted. Okay, so the pathology, main pathology is acromegaly and gigantism. Okay, so here is where increase in growth hormone is there. So there is increase in growth hormone with respect to acromegaly and gigantism. Okay, so the main targeted therapy is octreotide. Octreotide is nothing but a somatostatin analog. I told you, right? If there is increased GHRH, so that is what we are trying to target. Okay, to reduce the growth hormone. So somatostatin analog, that is the octreotide. Okay, then if for example there is increased growth hormone already in the body, so now we have to target the receptor. What is the receptor? Insulin like growth factor receptor, right? So this is the, I told you, right? This is what the growth hormone will convert into. So if we target the receptors of that particular tissue, then the growth hormone action won't be happening, right? So this is pegvisomant. Okay, please remember octreotide and pegvisomant. Okay, the best investigation, the gold standard investigation in acromegaly and gigantism is OGTT. Okay, oral glucose tolerance test. Okay, OGTT, please remember, it is not anything else. Okay, OGTT. Okay, it will be there in the option. Please go for OGTT. For screening test, we are going to go for IGF-1 levels. Okay, for screening it is going to be IGF levels. Okay, whereas for the gold standard will be OGTT. Okay, because OGTT will suppress the growth hormone. If it is not getting suppressed, that is how we will diagnose okay, the growth hormone is more in the body. Okay, then coming to other important hormone of the pituitary, that is prolactin. Okay, here let us see how it is getting released. Suckling and estrogen. Okay, when there is increased estrogen or when there is suckling reflex, what happens is there is reduced dopamine in the brain. Okay, so this reduced dopamine causes the release of prolactin. Okay, so this is how the prolactin will get released. Okay, there are two main actions of prolactin other than stimulating the breast glands. Okay, the two main action is it actually not two main action. I mean, yeah. So basically, what it does is it reduces the FSH and also the LH. Okay, so these are the two main action. Reason being, it directly inhibits the GnRH. When GnRH is reduced, then obviously the FSH and LH will be inhibited, right? So this is one of the major action of prolactin. Okay, so that is why 6 months of amenorrhea will be there after during lactation, because prolactin will be high. That is why the GnRH will be low, so there will be no ovulation. So this is how the prolactin will act on. And please remember, thyroid releasing hormone is also a stimulant for prolactin release. Okay, please remember, it is not only the suckling and estrogen TRH, that is thyroid releasing hormone, also can be causing prolactin secretion. Okay, so reason why this is important is in PCOD. We'll come back to PCOD in obstetrics. Please remember, this is where this particular action should come in. Okay, so that is why it is important, TRH. Okay, because in hypothalamic in hypothyroidism, it is one of the major case that PCOD can happen, PCOS can happen. Okay, so that is why it is important. And please note that we told, right, when the dopamine reduces, the prolactin releases. Okay, so that is why dopamine is the antagonist for prolactin. Okay, this is what our treatment also should be there in prolactinoma. Okay, we'll come back to that. So now with respect to the pathology of prolactin, that is prolactinoma. Okay, there are two types of prolactinoma. One is micro and macro. Okay, so the target is dopamine agonist, right? So if we increase the dopamine, there won't be increase in prolactin. So cabergoline and bromocriptine are the two dopamine agonists that can be used. Please note that in pregnancy also bromocriptine is safe. Okay, in pregnants, the drug of choice would be bromocriptine. Okay, so if not in prolactinoma, if it is a macro, if it is, this is a micro, if it is a macro thing, and it has to be like resected by transpenoidal surgery. Okay, this is how we do the resection of the prolactin gland. Okay, and please note that in growth hormone deficiency, we talked about growth hormone increase, right? Acromegaly, and we were discussing about gigantism. Whereas if there is growth hormone deficiency, these are certain drugs. Okay, somapacitan. Okay, then directly targeting insulin like growth factor deficiency is this thing. Okay, then coming to the next drug, the posterior pituitary. We discussed about two main anterior pituitary drugs, right? Growth hormone and the prolactin gland. Now prolactin hormone. So now we'll go on to the important hormone with respect to posterior pituitary, that is antidiuretic hormone, that is vasopressin. Okay, so let us see what happens if there is a basically what is the function of ADH. It goes and binds to the receptor, V2 receptor in our kidney, and causes antidiuresis, meaning the water won't be excreted out. Okay, so the urine osmolality will be increased because there is no water that is getting excreted out. All is getting reabsorbed. Okay, so antidiuresis. Okay, so this is the main function of ADH. Okay, suppose there is a pathology. There are two types of pathology. Either there might be increased ADH secretion, or there is no ADH secretion. So let us see the two pathologies, how it happens. SIADH, meaning there is syndrome of inappropriate antidiuretic hormone, meaning there is increased ADH. So what happens? There will be increased water reabsorption from the kidney. So that is what happens, right? So that is where the plasma osmolality will be decreased and urine osmolality starts increasing. Okay, so the concentration basically of urine will be increased. There is no water to dilute it. So in body, the body starts storing the plasma volume. Okay, so diagnosis will be water loading test. Okay, so normally when we load the water, antidiuresis should stop. Okay, but here it won't be suppressed. Okay, so normally it will be suppressed, but here in SIADH it won't be suppressed. Okay, this is how we diagnose the SIADH. Okay, then basically the patient will come to you. There is not enough urination that is happening, too much low urine and all. Okay, so that is when we'll do water loading test, and we should actually diurese, right? So but the patient wouldn't diurese. Okay, so the mainstay of treatment would be fluid restriction, basically to avoid water, and then Vaptans, okay, which will block the V2 receptors. So that is how we'll decrease. So this is the V2 receptor, and if we block it, so there won't be the action of antidiuretic hormone, and urination can happen. So this is Vaptans. Okay. Then coming to diabetes insipidus, here the opposite of SIADH. So basically there is no ADH that is acting on. So that is why there is no water reabsorption and too much urination is happening. So this is called diabetes insipidus. Diabetes means to let go. Okay, this is a Greek word. to let go. Okay, to let go is the meaning of it. Okay, insipidus is water. Okay, insipidus is water, to let go water, whereas diabetes mellitus means it is the honey. Okay, mellitus means honey. Okay, sweet flavored water is what mellitus means. So letting go sweet colored water. So that is what happens in diabetes mellitus, right? So that is the meaning of diabetes mellitus and diabetes insipidus. That's it. Okay. Then coming to the types of diabetes insipidus, so the insult might be, so now basically ADH is not getting secreted, right? So insult might be because of the ADH, so it is a ADH problem, right? So it can be either the central level, at the central level the ADH is not getting secreted, or at the nephrotic level where in the kidney the ADH receptors are affected, or probably because the patient is drinking too much water. Okay, so that is primary polydipsia. Okay, so these are the types of diabetes insipidus. So let us see how we will diagnose this. So now there we gave the water and we saw whether the diuresis is happening or not. Now here what we are trying to do is we are trying to deprive the water and see whether the diuresis stops. Okay, so that is the difference here, water deprivation test, whereas there we did water loading test. Okay, so what we see is, if we deprive the water, if it is primary polydipsia, suddenly the diuresis will stop. Then that is how the urine osmolality will increase. So urine concentration will decrease, right? So that is how the primary polydipsia is diagnosed. Then coming to if there is no change in urine osmolality even after depriving water, then what we'll do, we'll try to give desmopressin. Okay, so desmopressin we'll give. Okay, so then what we'll do, we'll check for the change in urine osmolality. Okay, if desmopressin works, it means that there is increase in if desmopressin work, it means that it will increase the osmolality, right? Meaning it will stop the urine from diuresis. So that is when we will judge it as, we will diagnose it as central diabetes insipidus. So desmopressin we gave, it acts like a antidiuretic hormone. Okay, so then if for example even after giving desmopressin there is no change, then it means that there is some issue with the receptor. Okay, so receptor only the issue is there. So that is when we'll diagnose it as nephrogenic diabetes insipidus. So two treatments are, so now desmopressin I gave and it worked, meaning I'll give desmopressin only for prescription, right? So desmopressin is the prescription for central diabetes insipidus, whereas for nephrogenic diabetes, what we'll target is, we cannot target the receptor directly. So that is why we'll give thiazides. Why thiazides, I'll explain it in nephrology. Okay, so that is how we target the SIADH and the diabetes insipidus. Okay, this is all and everything you need to know with respect to pituitary gland. Now moving on to one of the favorites, that is thyroid gland. Okay, so thyroid gland, in thyroid gland, so what we'll do is, we'll see the physiology first and then we'll see how the pathologies of thyroid gland will act on. Okay, so it is the TRH, that is a thyroid releasing hormone from the hypothalamus, that it came in, right? So thyroid releasing hormone will be releasing the will be acting on pituitary gland. From pituitary gland, TSH, that is thyroid stimulating hormone, will be released. So what happens is, it will go to thyroid, and in thyroid there is thyroid stimulating hormone receptors. Okay, so thyroid stimulating hormone, where exactly, do you remember from general physiology? I told you, right? The thyroid stimulating hormone will always go and act on the thyroid receptors that is present on the thyroid stimulating hormone, will go and act on the nucleus. Okay, so nucleus of that particular cell. Okay, and even the thyroxines, okay, so the hormones that is T4 and T3 also will go and act on the nucleus of the cell. Okay, so please remember, nuclear acting hormones are these things. Okay. In basically, thyroid follicular cells are the main acting cells of the thyroid gland, right? So there are three actions that TSH does. Okay, one is it will increase the iodine uptake. The other one is it will activate the sodium iodide transporter. The other action is it stimulates the thyroglobulin. Three different actions the thyroid stimulating hormone will have. Okay, so now once the iodine uptake is increased, so the sodium iodide import will start will start taking in the sodium, the iodine. Okay, so the channel name is pendrin. Okay, please remember the name of the sodium import channel is pendrin. Okay. So now, after taking the follicular cell takes in the iodine, here it will combine with the thyroglobulin. Okay, so this is known as TPO oxidation. Okay, so now here the iodine will combine with thyroglobulin. Okay, and together form the thyroid ioglobulin molecule. Okay, so now this particular reaction is called as organification. Okay, so organification will happen when thyroglobulin is combined with iodine. Okay, so the hormone that is acting here is TPO. Okay, thyroid peroxidase. Okay, TPO is what is acting on which is required for organification. We'll come back to that why TPO is important. Okay, so when I tell you about the clinical significance, we'll get to know. Okay, so now that the iodine thyroglobulin complex is formed, this is what will form the T3 and T4. Okay, so T3 and T4 will be formed like this. Okay, then what happens is it will be released from the thyroid gland. So whenever thyroid hormone is required, so it will go and get released. Okay, so and it will go to the peripheral tissues. So in peripheral tissue, T3 is most potent. Okay, so even though we are releasing the thyroid gland is releasing it as the T3 and T4, the T4 will also be converted into T3 when it goes to peripheral tissues. Okay, wherever the action is needed. So basically the nucleus, right? So that is where the target of T3 and T4 is. Okay, so this is the exact physiology how the thyroid hormone is getting formed. Okay, so from TRH to T3 and T4. So now let us see the clinical significance of it. Okay, so the first thing is, I told you, right, the iodine uptake. Okay, there is something called as Jord-Basedow effect, where there is iodine induced thyrotoxicosis. Okay, there is increased amount of iodide, and it will cause thyrotoxicosis. This is known as Jord-Basedow effect. Contrary to that, there is something called Wolff-Chaikoff effect. Okay, so where there is IV Lugol iodide will use, and it will inhibit the thyroid release. Okay, Wolff-Chaikoff effect is where we'll use the iodide to reduce the thyroid level, whereas here increased iodide will cause the thyrotoxicosis. So that is why please differentiate between Wolff-Chaikoff effect and Jord-Basedow effect. Okay, so these are two contrary things. Okay, then coming to, as I was telling about organification, we can directly target this organification and reduce the hyperthyroidism. So this is where PTO, that is propyl thiouracil, will come in. Okay, so this has a inhibitory action on organification, so the iodine thyroglobulin complex won't be formed. So then the other one is carbimazole and methimazole. This is what we use for hyperthyroid patients, right? So carbimazole, methimazole is what we use, right? So this is the target that we are trying to do. Then the one more major clinical significance is, so you know that, right? TPO. Okay, so the TPO is what it targeted in Hashimoto's thyroiditis. Okay, Hashimoto's thyroiditis, what happens is there is anti-TPO. Okay, so anti-TPO goes and binds to this TPO receptors and destroys it. So that is how there is no formation of iron thyroid globulin at all. So if TPO is destroyed, so that is why they will have hypothyroidism. Okay, so this is the main action of anti-TPO. Okay, hypothyroid. Okay, so this is how the clinical significance of this is. Okay, so now we learned about Wolff-Chaikoff effect also. Then one more thing is, I told you, right, in peripheral tissues there is conversion of T4 to T3. Suppose if we target this particular conversion, we can reduce the hyperthyroid effect, right? So that is where the PTO acts on. PTO has two functions. One, it can reduce the organification, and also it can act on the peripheral tissue conversion of T4 to T3. So that is why PTO is the best drug. Okay, and also it is safe in pregnancy. So that is why propyl thiouracil is one of the best drug for hyperthyroidism. Okay, so this is the entire action of follicular cells. Then the physiology of follicular cells we learned. There is something called as parafollicular cells also, right? So in thyroid gland there is a thyroid follicular cells, there is stroma. Okay, so in stroma there is something called as parafollicular cells. Okay, C-shaped parafollicular cells are there. So this is what the calcitonin will release. Okay, so it will release calcitonin, which reduces the calcium levels in our body. Okay, the increase in calcium levels, we know that, right? From orthopedics it was PTH, the parathyroid hormone. This is the thyroid hormone, that is calcitonin is a thyroid hormone. Parathyroid hormone will increase the calcium levels in our body, whereas calcitonin will reduce the calcium level in our blood. Okay, so these two are contrary to each other. Okay, so this is the entire physiology with respect to thyroid gland. So now we'll dive into the specific pathologies with respect to thyroid gland, that is hyperthyroidism and hypothyroidism. Okay, so then we'll come to the neoplasia. Okay, so the cancers of thyroid gland, that is what is important with respect to surgery, right? So now with respect to medicine, so hyperthyroidism, the main clinical feature is sweating. Okay, so sweating, please remember sweating. Okay, so this is a mnemonic. Okay, sweating is there, weight loss is there, in that way. Okay, so this is the mnemonic that you should remember. Okay, so the major hyperthyroidism disease that we all see is Graves, right? Graves disease, thyrotoxicosis. So what happens in thyrotoxicosis is basically in Graves diseases, so there is antibodies similar to TSH. Okay, so TSH will stimulate the thyroid gland, right, to release the T3 and T4. There are certain antibodies which will act like TSH and go and stimulate the thyroid gland on its own. So this is the antibody mediated thyroid release. Okay, so it causes the stimulation and cause the release of T3 and T4. Okay, so this is the pathogenesis of Graves disease. How do we target the Graves disease and how do we solve it is, how do we manage it is, so basically we'll give radioactive iodide. Remember, right, I told you Lugol's iodide, like Wolff-Chaikoff effect. So based on Wolff-Chaikoff effect, I told you, right, iodine will reduce the T3 T4. So that is how the target of radioactive iodide is. Okay, so then it also destroys the thyroid. Okay, so that is how the radioactive iodide will work. Then the other one is PTU and azoles, methimazole, carbimazole. I told you, right, all the actions of PTU and azoles, how it acts on. Then if there is increased mass, so it will basically be enlarged, right, thyroid gland. So if it is affecting the airway and all, we'll go for surgery. Okay, surgical thyroidectomy. Okay, so this is the management of hyperthyroidism. Coming to hypothyroidism, so the clinical feature will be mom is so tired. Mom so tired is the mnemonic that you can basically think of. So basically the person will be tired. Okay, so tired and weight gain will be there, obesity will be there, in that way. Okay, so mom so tired is the mnemonic you can remember. So basically what happens is there is a reduced thyroid stimulating hormone. Okay, or there might be reduced iodide. So this is separate, okay, so there might be the reduced iodide, or we discussed it in Hashimoto's, there might be anti-TPO. Okay, all these things might lead to reduced T3 and T4. This is the pathogenesis of hypothyroidism. Okay, so how do we manage it? By giving the thyroxine. Okay, so thyroxine is reduced. Just by giving thyroxine, we are trying to manage the patient. Levothyroxine is what we give, right? So from 12.5 mg we'll start, and if it starts improving, then again in the same way we try to stop decrease the doses, right? So that is how we target it. So please remember, it is before food. So thyroid tablets are given before food. Okay, so please remember it. Then there is increased cholesterol or hypercholesterolemia in hypothyroidism, because there is reduced LDL receptor activation. See, basically all these thyroid hormone, what it does is increase the metabolic activity, right, in certain particular cells. But what happens is, we discussed in biochemistry, right, there is LDL receptors. If the LDL receptors that doesn't take in the LDL molecules, it will stay in the blood itself. So this is the target for LDL. This is the main action of LDL receptor. But what happens is in hypothyroidism, there is no action of LDL receptor. So that is why all the LDL molecules will start staying in the blood itself. So that is why hypercholesterolemia will be there. Okay, this is the thing. Okay, the two emergency cases with respect to hyperthyroidism and hypothyroidism we'll discuss. Okay, one is thyroid storm. Okay, thyroid storm, where there is it is an emergency case of hyperthyroidism, whereas myxedema coma is the emergency case of hypothyroidism. Okay, so let us see what happens. So if there is a pre-existing hyperthyroidism, okay, so some hyperthyroid patient is there, certain trigger, okay, some certain trigger, okay, will cause increase in T3 and T4. So what happens is, this trigger might be some surgery or something else might trigger it. Okay, or some infections or and all will be the triggering factor, some environmental factor. Suddenly there will be increased surge of T3 T4. Already T3 T4 is raised, but then if increase in T3 T4 is there, then it might lead to thyroid storm. Okay, this is an emergency. That is where we'll try to reduce the action of it through propranolol. Okay, propranolol will use and reduce the beta action. So sympathetic, everything, heart rate, everything will be raised. So that is where we'll go and give the propranolol first through beta blocker, and then we'll give PTO. Okay, and also we'll supplement them with corticosteroid to reduce the adrenal crisis. Okay, because sympathetic action is too much raised, so all the hormones might get reduced in body. So that is where we have to supplement with corticosteroid. So that is the thing. Okay, so in question, this is a definite question. So if they ask you whether the PTO that you are choosing or propranolol, it's the propranolol first. We are targeting the sympathetic action, and then we are going for definitive action. Okay, PTO. Okay, please read the question and then answer it. Okay, coming to myxedema coma. So basically what happens is, there is already existing hypothyroidism is there. So some trigger, as I told you, with respect to hyperthyroidism. So suppose there is hypothyroidism and someone is doing surgery. Okay, suddenly what happens is, there is a reduction in T3 T4. So all the sympathetic action is lost, and sudden vasodilation might happen, and the patient might collapse on the table itself. So this is why it is important to know the thyroid status before any surgery. Okay, so how do we manage it? Basically, IV hydrocortisone is given. Okay, then we'll give IV T3 T4. Okay, so IV T3 T4 can be given before any surgery. Okay, so if we are targeting, IV T3 T4 can be given, and then we can allow them for surgery. Okay, so also please manage the sodium chloride level. Okay, then we'll go for the specific management of hypothyroidism. Okay, so this is how we can manage the two cases. There is also called something called as myxedema madness, where auditory hallucinations can be seen. Okay, in myxedema coma patient, auditory hallucinations might happen. Okay, so this is the emergency situation with respect to thyroid gland. Okay, now moving on to thyroid neoplasia. I told you, right, there are the two kinds of cells, that is follicular cells and parafollicular cells in our thyroid gland. Okay, so there are benign neoplasia and malignant neoplasia. Malignant neoplasia, most of the time it will be secondary. Okay, so benign neoplasia are not much important. We know we know that, right? We'll remove that particular nodule, or we'll do just a lobectomy and all. Okay, so based on whether the patient wants it to be removed or not, we'll do it. We'll do the FNAC and we'll do the FNAC, and then we'll do the diagnosis, because here the biopsy can't be done. You know that, right? Biopsy can't be done in thyroid issues, because there is increased chances of recurrent laryngeal nerve injury, right? So that is why we won't be doing biopsy. Where else we didn't do biopsy? You know that, right? NPC. Okay, NPC nasopharyngeal carcinoma, and in juvenile not in NPC, sorry, JNA, juvenile nasopharyngeal angiofibroma. Okay, here also there is increased risk of bleeding. That is why we are not doing biopsy. Please remember these two things where we don't do biopsy. Then coming to malignant thyroid neoplasia, I told you, right, there are two kinds of cells in thyroid gland, follicular and parafollicular cells. Okay, parafollicular cells neoplasias can be differentiated and undifferentiated type of follicular cell neoplasia, whereas parafollicular, it is the medulla, right, medullary stroma. Okay, so that is what causes the medullary thyroid cancer. Okay, there is one more thing, that is lymphoma, if the lymph nodes are involved with respect to the thyroid gland. Okay, so this is the classification for thyroid neoplasia. Let us see one by one. So in follicular cell carcinoma, there are two types of carcinoma. Okay, so in differentiated carcinoma, there are two types, that is papillary and follicular. Okay, then coming to undifferentiated, I told you, right, anaplastic type of carcinoma. Wherever in our body, if it is an undifferentiated type of carcinoma, it is going to be anaplastic. Okay, so remember that. Then coming to papillary thyroid carcinoma, more than 80% of the thyroid carcinomas occurrence will be papillary thyroid carcinoma, whereas it is 10 to 15% with respect to follicular, and 1 to 2% in anaplastic carcinoma. Okay, it is the BRAF gene. Okay, please remember BRAF gene, BRAF V600E is the gene. Please remember all these things. Okay, please write it down in your sticky note. This is very, very important. Okay, BRAF V600E is the gene that is mutated here with respect to papillary carcinoma. They'll also give RET. Okay, so RET also they will be giving it. So please choose BRAF. It is more involved with papillary thyroid carcinoma than RET. Okay, so the main pathognomic, if we take a FNAC, will be the orphan Na nuclei. Okay, orphan Na nuclei will be there. So blind cells will be there. There is no nucleus within the cells. So that is how the orphan Na cells will look like. Okay, so with respect to follicular carcinoma, it is RAS. Okay, so remember, this is the gene that is mutated. In undifferentiated carcinoma, it is a very bad prognosis. Okay, it is very for fast growing, and it has very bad prognosis. Okay, here also, here it is going to be P10. Okay, P10 is what is mutated here. Coming to medullary carcinoma, RET gene. Okay, so RET with both in medullary and in papillary, it is going to be RET, but in papillary it is going to be BRAF V600E. That is more common than RET. So please remember that. Okay, so then coming to the management part of each of them. So for basically the follicular and papillary thyroid carcinoma, it is going to be a TSH we'll be doing, then ultrasound, TSH for everyone will be doing. So ultrasound scan will be doing, and then we'll do FNAC and do the staging. Okay, so then after that, so once the staging is done, we'll decide whether lobectomy has to be done or total thyroidectomy has to be done. Okay, so then after doing the surgery, we'll go for radioiodide therapy if needed. Okay, so radioiodide therapy if needed. So now, because we have removed the entire thyroid gland, so levothyroxine supplementation is done. Okay, so that is the thing with respect to follicular carcinoma. Coming to anaplastic, I told you, right, it is very aggressive. So here also we'll do ultrasound scanning, and then we'll go for FNAC and biopsy, because here we can salvage the tissue because there is too much growth. Okay, so that is why we'll go for biopsy here, and then we'll go for CT to see what is the extent of the growth, because all the neck and all will be involved, right? So that is why we'll go for CT, and we'll do the BRAF gene testing. Okay, so management will be airway, then surgery if possible we'll do, and targeted therapy can be done in anaplastic carcinoma. Okay, so this is how we'll manage them. Okay, because it is very difficult to resect anaplastic carcinoma. Then coming to management of medullary thyroid carcinoma, the stroma, right? So here also we'll be seeing the USG, but here not TSH, it is going to be calcitonin, right? Medullary parafollicular cells. So calcitonin levels we are seeing. Then we'll do the gene testing, that is CEA and RET and MEN2. Okay, so I'll come back to what is MEN syndrome at the last when we'll be discussing about adrenal gland. So MEN2 is so here the medullary thyroid carcinoma is involved. Okay, MEN2A. Okay, then coming to the specific management, it is going to be total thyroidectomy that we do along with the neck dissection. Okay, so neck lymph nodes are also removed. Okay, then after that RET therapy, because RET is the gene that is involved in medullary thyroid carcinoma, right? So this is the entire neoplasia thing of the thyroid gland. Okay, so now we'll move on to the next gland right next to the thyroid gland, right behind the thyroid gland will be there, that is parathyroid gland. Okay, so we'll see the physiology first. Okay, so what happens here is, so there is well, how does the parathyroid hormone work? So basically, when there is a reduced level of calcium, the parathyroid hormone works and it tries to increase the calcium level in our blood. So basically, that is the main action. How it does the increase in calcium level of the blood? So basically, it goes and targets the bones. Okay, so it will cause bone resorption, and also it causes the urinary calcium resorption. Okay, and also it tries to excrete the phosphate from the urine. Okay, because phosphate tries to hold the calcium with itself. Okay, so that is why there is increased amount of calcium like excretion along with the phosphate. So that is why, to avoid that, PTH, what it does is it reduces the phosphate level in our blood. Okay, so this is how it does. Okay, the two main action of parathyroid hormone to increase the blood levels in our blood calcium levels. Okay, so the let us see the pathologies. So it is going to be hypoparathyroidism and hyperparathyroidism. Okay, so hypoparathyroidism mostly happens because of accidental removal, right? When we are doing thyroidectomy surgery, we do the accidental removal. Okay, that might happen. So how do we diagnose whether it was a lymph node or a parathyroid hormone that was removed? So basically, we try to float it, right? So it will basically be golden yellow color, remember that. So golden yellow color it will be there, and if for example, if it floats, it is going to be parathyroid hormone. We have accidentally removed it. So now that we have removed it, what do? We try to attach it to the brachioradialis. Okay, brachioradialis, where we will try to attach back the parathyroid gland if we have accidentally removed it. Okay, so what will be the clinical features if in a patient with respect to if there is an accidental removal? Is there might be spasm. Okay, so spasm, how do we check it? There is Chopstick sign and Trozius sign. Remember, please go check the video based question based on how we do chopstick sign and Trozier sign. You know that, right? We try to tap on the cheek, and at the level of ear we'll try to tap and check for chopstick sign, whereas in Trozier sign we'll like inflate BP cuff and see whether there is carpal and pedal spasm is there. Okay, so that is how we check Trozier sign. Please go check a video of this. Okay, that is all about hypothyroidism. Now coming to hyperparathyroidism. So basically, what happens is when there is hypercalcemia. Okay, so let me tell you how we diagnose the hyperthyroidism. Okay, so basically, if there is hypercalcemia, it means that, so there might be PTH that is causing the hypercalcemia. Okay, so how do we know that there is hypercalcemia? The main clinical features with respect to hypercalcemia will be bones, stones and groans. Okay, bones, stones and groans will be there, and oval tones will be there. Okay, so these are the clinical features with respect to hypercalcemia. So now a patient has come to you, there is increased stones and all, and there is high level calcium when we do the calcium levels, okay, in the labs. Okay, so now what we do, we'll see whether the parathyroid hormone that is causing the hypercalcemia or it is something else. Okay, so if we'll check for the parathyroid hormone levels, if it is high, then it is the primary hyperthyroidism. I told you, right? Primary means the gland is involved. Okay, now for example, the parathyroid hormone is low but still the calcium level is high, then we'll try to see whether it is malignancy, that is some malignancy that is causing the hypercalcemia. I told you, right? In the paraneoplastic syndromes, we'll get to see hyperparathyroidism in squamous cell carcinoma. Okay, so this is where it comes in. Okay, hypercalcemia can be caused by squamous cell carcinoma of lung. Okay, so that is where it comes in. Then vitamin D toxicity might have caused the hypercalcemia, or it is the thiazides. Okay, thiazides will cause calcium reabsorption, right? So we'll come back to thiazide function in nephrology, but for now remember, so this is how PTH is low, but still the calcium is high, meaning, so this is the etiologies behind it. So how do we manage is basically 0.9% of sodium chloride will give, and will give calcitonin. So calcitonin basically binds the calcium and removes it, right? So this is how we manage it. Mainly hydration, okay? So if hypercalcemia is suspected, give the hydration, okay? So the gold standard investigation with respect to thyroid gland is system scan, okay? System scan is the gold standard investigation. Please remember this, okay? So this is how we diagnose the thyroid gland and thyroid gland function, okay? So rickets, okay? So with respect to rickets, I have explained all this in orthopedics. Please go through my orthopedic chapter once again. You would be knowing what happens with respect to rickets and how the phosphate level decides whether it is the phosphate that is causing the rickets, or something else, or the parathyroid hormone that is causing the rickets, okay? So please go through the orthopedic video, you'll get to know, okay? Now we'll go to the next chapter, that is breast, okay? So now thyroid gland is done. So one by one I'm coming. Head and neck, we finished thyroid and hypothalamus gland. Then we went on to the chest part, neck part, that is thyroid gland. Now coming to the chest part, that is breast, we'll discuss, okay? So breast with respect to the endocrine gland, we'll discuss everything, surgery, everything we'll discuss, okay? So now let us see what are the hormones that act on the breast, okay? So estrogen will cause the ductal growth, okay? Progesterone will cause the lobular alveolar growth, okay? Then prolactin, we learned it, right? Milk production will happen, whereas oxytocin will cause it to eject, okay? So these are the four hormones that act on the breast, and it is very important to know this, okay? Because estrogen, progesterone is very important, because ER/PR positive breast neoplasia will be helpful, because that is what causes the breast growth, right? So this is the target for our ER/PR positive breast cancers, okay? So this is the thing. So now with respect to breast cancer, so let us see the mass, okay? Suppose if there is a mass in breast, it is not always the neoplasia or the breast cancer. So let us see what are the different things. It might be a cyst, it might be a solid mass, or it might be an inflammatory mass, okay? So these are the things, okay? Coming to cystic mass, it might be a galactocele, a milk filled galactocele might be there, or it might be a oil cyst, okay? So it is a fat tissue, right? So this might cause into a cyst, okay? Then coming to solids, it is going to be benign and malignant, okay? So benign masses are fibroadenoma, lipoma, or a phylloid tumor can be there, okay? Coming to malignancy, if it is a in situ, it is going to be ductal carcinoma in situ, whereas invasive can be ductal invasive or lobar invasive carcinoma. And also the surrounding tissue, if it is getting involved, it is going to be medullary carcinoma, okay? So this is how you can classify the mass of a breast, okay? Then coming to inflammatory masses, it can be mastitis, breast abscess, or a fat necrosis, or a ductectasia, okay? So this is also called as Zuska's disease, okay? Ductectasia is also called as Zuska's disease. So these are the things when it is an inflammatory meaning it will be painful and redness will be there. So this is how we can differentiate between the masses, whether it is solid mass or the inflammatory mass, okay? Then let us see the protocol that we follow. Suppose a patient comes to you with a breast mass, okay? So what is the protocol that we follow, okay? So remember, screening test is done for all the women above 40 years, okay? So for at the 40th year birthday, we start screening of all the breast, okay? Whether there is mass or no mass, we'll do the screening test once at least, okay? Screening is mammography that we do, okay? So now let us see, a patient has come to you with the breast mass, like, then how will you diagnose, okay? So there is something called as triple assessment, right? So this is the gold standard, triple assessment. What is triple assessment? It is basically we do clinical, imaging, and needle based diagnosis, okay? Clinical diagnosis, imaging based diagnosis, and needle diagnosis, and then we'll come to a conclusion what exactly that mass is, okay? So in clinical, suppose now I am examining the mass. clinically. So if it is a cystic lesion, it is going to be soft and mobile. Okay. If it is a solid benign mass, it is going to be mobile, non-tender and well defined. Okay. So if it is a benign thing, if it is a solid and malignant, it is going to be hard, irregular and fixed. Okay. So all of this will be painless. Please remember, painful was in inflammatory. Okay. So that is what. So inflammatory, it will be pain and red will be redness will be there, and fever might be there. Okay, might be there. Okay, so not always, fever might be there. Okay, that is how we diagnose, we differentiate between solid and inflammatory mass. Okay, so this is the thing. So there might be nipple discharges. Okay, so this is how, when we take a look at the mass, that is how we differentiate between each masses. Okay, now coming to image based. So if it is a cystic lesion or a cystic mass, it will be a thin walled. Okay, the wall will be thin, okay, and round, oval shaped. Okay, then coming to solid benign, if it is going to be there, then it is going to be oval, well defined, homogeneous structure. Okay, homogeneous structure it will be there, and it will be well defined. Whereas here, if it is a malignant tissue, it is going to be irregular. Okay, irregular mass will be there when we take a look at the ultrasound. Okay, then coming to abscess, that is in inflammatory mass, there will be abscess. Okay, so mass will be there, there will be abscess coming out, sinus might be there and all. Okay, so that is how we differentiate. Then coming to mammography, we will do both ultrasound and mammography with respect to imaging. Okay, imaging based diagnosis, we'll do ultrasound and then mammography, we know that, right? If it is a benign thing, it will be oval and well circumcised, and if it is a malignant thing, it will be irregular and spiculated. Okay, basically we will be seeing the calcium deposits. Okay, so this is how it would look like in benign, whereas it will be irregular with respect to malignant. Okay, so that is how we will be diagnosing the by image based. Okay, then what we do is needle based diagnosis. So needle meaning we'll do the core cut biopsy. Okay, so core biopsy will be done, and if it is a solid benign lesion, it is going to be, if it is a phylloid tumor, basically it is going to be a leaf like structure. Okay, leaf like structure it will be there. Okay, so phylloid lesion, and with respect to solid malignancy, there will be differentiated symptoms with respect to that particular malignancy. If it is a DCIS or if it is an invasive carcinoma, it will be different from each other. Okay, so this is how you diagnose the breast masses. Okay, so now that I have diagnosed it, so how will we manage? So each of these masses will have a different types of management. Okay, so coming to cystic mass management, it is going to be nothing. Okay, we'll be doing nothing, or else if the patient needs it to be if they want to get it removed, it is going to be aspiration that we are going to do, and remove all the fluid from that particular cyst. Suppose if it is a solid mass, then we'll decide whether benign or malignancy, right? So if it is a we diagnosed it, right, from all the above above discussion. So what we'll do is we'll do the follow up. Okay, so with respect to benign lesion, all we do is follow up every 6 months. We'll tell them to come back and we'll see how the lesion has been. Then coming to malignant breast masses, so what we do is we'll decide it as cancer, right? So what we do is, first thing is ER, PR and HER hormone testing we'll do. Okay, so whether it is a ER, PR and HER, what type of cancer it is, we'll do. Then we'll do staging. Okay, how do we staging is by CT and PET scan. Okay, so this is how we do staging. Okay, so now after doing the staging, suppose if there is a small lesion and there is no not much importance is needed, so then we'll go for breast conservative surgery, where we'll do lumpectomy plus the sentinel node biopsy. What is sentinel node? The first node that the breast is draining into. Okay, so sentinel node biopsy. After doing the staining, we'll decide which is the sentinel node, and we'll do the sentinel node biopsy. Okay, so this is how we do the breast conservative surgery. Okay, in the starting stages. If it is malignant and the stage has been increased, so that is when we do mastectomy. Okay, so mastectomy will be done. So after neoadjuvant therapy. Okay, so first we'll give neoadjuvant therapy and then we'll shrink the mass and then we'll do the mastectomy. Mastectomy can be done in three ways. Okay, Halstead's, Petty's and Auchincloss. Okay, so there are three methods of mastectomy. So in Halstead we'll be removing both pectoralis major and minor. Okay, Halstead will be removing both pectoralis and pectoralis major and minor, whereas in Patty only the pectoralis minor is removed, whereas in Auchincloss none of them will be removed. Okay, so this is the major difference between these three mastectomies. Okay, so neoadjuvant chemotherapy was done. So now with respect to some points with respect to adjuvant chemotherapy is so I told you, right, we'll be deciding whether it is ER positive, PR positive. If it is a ER positive, it has very good prognosis. Please remember, ER positive has very good prognosis. Coming to adjuvant chemotherapy, there are many drugs like taxanes and all these drugs. Okay. Then coming to, if it is a HER2 positive, it is very dangerous. HER2 positive, what we'll do is we'll do the adjuvant chemotherapy with trastuzumab. Okay, so along with trastuzumab we'll do. Okay, if it is a triple negative, so it is not having any hormones, so it is going to be very difficult to target the mass, right? So triple negative is very bad prognosis. Okay, so that is where we'll go AC plus taxanes and platinum based therapy for triple negative masses. Okay, so this is all and everything you need to know with respect to breast and breast cancer. Okay, so you got to know all the management, right? So now let us with respect to neoplasia we have learned. Now if it is a inflammatory breast mass that is there, so what do we do? So if suppose it is a mastitis, then what we are going to do is, for pain management, NSAID is given and dicloxacillin is the drug that we are going to give. Dicloxacillin is the drug that we are going to give. If they need it, we are going to drain. Okay, if there is an abscess that is there with respect to mastitis, then we are going to give we are going to drain it. Okay, then coming to ductectasia, meaning ectasia meaning there is enlargement of the duct. Okay, so dilation of the duct is known as ductectasia. Okay, bronchiectasis. Okay, ectasia means basically dilation. Okay, so ductectasia, the main management will be ductoscopy we'll be doing. We'll see whether it is a benign thing or a malignant thing. Benign, if it is there, we are going to follow up, whereas if it is a malignant ductectasia, then we'll go for same cancer like management. Okay, we'll do the staging and all, then we'll manage it that way. Okay, so this is the entire thing that you need to know with respect to breast. Okay, so now we'll move on to pancreas and all the diabetes management that we are supposed to do. Okay, so now we'll go on to diabetes mellitus. So with respect to diabetes mellitus, the meaning of the word is, I told you, right, diabetes means letting go, whereas mellitus means, so basically it is a honey or a sweet liquid. Okay, so we are letting go the sweet liquid. So what are the two types of diabetes mellitus? Is type 1 diabetes mellitus and type 2 diabetes mellitus. Okay, so type 1 will be most common in childhood and adolescence, whereas type 2 will be in by the adulthood. Okay, then coming to type 1 diabetes mellitus. So what is the pathogenesis is? It is basically autoimmune destruction of the beta cells. Okay, so beta cells in the pancreas is what secretes the insulin. So destruction of it will cause the type 1 diabetes mellitus, whereas type 2 diabetes mellitus, the pathogenesis is basically insulin resistance. Okay, the clinical features will be polyuria, polydipsia and weight loss. Okay, so this is the main three clinical features with respect to diabetes mellitus. This is what they'll come to you to the clinic or the hospital, right? So this is the thing. So then with respect to diabetes type 1, there are stages. Okay, so stage 1 is asymptomatic, nothing will be there. Okay, stage 2 will be leukocyte infiltration will be there. Okay, then stage 3 will be reduced insulin production with symptoms will be there, and stage 4 will be long standing type 1 diabetes mellitus. Okay, so these are the 4 stages of type 1 diabetes mellitus. The mainstay of treatment, the management is insulin. Okay, then coming to type 2 diabetes mellitus, the main complications with respect to type 2 diabetes mellitus are microvascular and macrovascular. See, either they might come to the hospital with polyuria, polydipsia and weight loss symptoms, or else there might be complications that they might present with. Okay, microvascular complications will be retinopathy, nephropathy and neuropathy. Neuropathy meaning polyneuropathy will be like they'll be having tingling sensations in the lower limb, upper limb and all. So this is what the patient might come up with the come to the doctor with. Okay, whereas macrovascular complications might be myocardial infarction, stroke and peripheral artery diseases might be there. Okay, so this is all because there is increased glucose which might convert into fatty acid. This all we discussed in biochemistry, right? So there is increased glucose which is not being taken up by the body, so all this glucose will convert into fatty acid. All this fatty acid will go and get stored in the blood vessels itself and might lead to atherosclerosis. So atherosclerosis will be the complication of will lead to complication of these things, right? MI, stroke and peripheral artery disease. So that is the thing. Okay, then coming to other infection, other complications, that is skin infections might be there, ulcers might be there, trophic ulcer and all, and discoloration of the skin, like acanthosis nigricans, because it is also it is basically a metabolic disorder, right? Discolorations might be there, hyperpigmentation. Then coming to urinary tract infection might be there because there is too much glucose that is passing through the urine, and organisms can grow when there is urine glucose, right? So the UTI can happen. Then candidiasis, basically fungal infections might be increased with respect to type 2 diabetes mellitus. Okay, the two main emergencies are DKA and HHS. Okay, diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome. Okay, so this might be happening with respect to emergency situation of type 2 diabetes mellitus. Okay, so let us see how we manage the patients. Okay, so first thing is again, okay, birthdays, I told you, right? We'll be doing the questions might be on birthdays. Okay, so 45-year-old, I told you, right? 45-year-old, we will be will be telling them to get retinal examinations. I told you, right, to diagnose whether hypertension is there or not. So until 45-year-olds. Okay, so 35-year-old will be for diabetes screening. Diabetes, for everyone who is a 35-year-old will be doing diabetes screening. Okay, this is a birthday gift that we'll do. Okay, and 40 for 40-year-old women, it will be the triple assessment that we do for basically breast screening. Okay, triple assessment breast screening can be done at 40-year-old women. So these are the birthday gifts. Okay, so remember that. Okay, then coming to specific managements, we'll be there are three categories that we categorize the patients into. So that is normal glucose, pre-diabetic and diabetic. Okay, so fasting level, if it is more 100 to 125 pre-diabetic and more than 126 diabetic. So these are the certain values, please go through this. Okay, so HbA1c is what we decide the treatment on, right? So basically HbA1c more than or equal to 6.5 is diabetic, whereas 5.7 to 6.4 is where we categorize them as pre-diabetic. Okay, so 2 hour OGTT also more than 200, if it is there, then it is diabetic. 140 to 190 will take them as pre-diabetic. Okay, so these are the things with respect to categorizing what the patient should be in, because for each category it is a different management. Because see, pre-diabetic, it is going to be lifestyle management because it can be reversible. Okay, so diabetes can be reversible with respect to pre-diabetic condition. Okay, so if needed, metformin will be given if the if there is a less than 60-year-old but less than 60-year-old patients, if he's a diabetic, pre-diabetic, then we'll consider metformin. And if the BMI is more than or equal to 35, then we are going to go for metformin. Okay, so this is with respect to pre-diabetic management. With the specifics of diabetic management, we'll decide based on the HbA1c value. Okay, if it is less than 7.5 HbA1c, we are going to go for metformin, single drug. Okay, then we'll tell them to come back. Okay, if the if the diabetes is controlled, if the after 3 months we are going to tell them to follow up, right? So each month they'll come at the beginning, so we'll decide what dose of metformin should be given based on their visits. Okay, then for example, if the diabetes person again comes to you and his diabetes has increased, for example it is from 7.5 to 9, then we'll add a other drug, that is dual therapy along with metformin, that is one additional drug can be given. So deciding this additional drug is very important, because for each additional drug we'll be deciding based on cost and other core symptoms or the core diseases that is present with the diabetes. So for example, if there is a CVD, then cardiovascular disease, then we are going to go for CGLT2 inhibitor and GLP-1 agonist can be used. Okay, an additional drug along with metformin is we can go for this dapagliflozin, empagliflozin and all these things, right? SGLT2 inhibitors. Then coming to GLP-1 agonist, it also can be given. Okay, so this GLP-1 agonists are the new type of drugs. So that is the Ozempic and all these things, right? You know, Karan Johar, Ozempic, all these things. Ozempic is one of the best drug now in the current market. Okay, along with metformin. So then for heart failure, it is going to be heart failure and CKD patient, it is going to be SGLT2 inhibitors and GLP-1 agonist that can be given. In CKD specifically, glipizide is the drug of choice. Okay, please remember, glipizide will be the drug of choice with respect to CKD. Okay, then coming to obesity, GLP-1 agonist, because GLP-1 agonist will cause the weight loss. Okay, also helps in weight loss. So that is why obesity, GLP-1 is the best drug. Please avoid sulfonylureas because it causes weight gain. Okay, weight gain, sulfonylureas, glimepiride and all will cause weight gain. Okay, so weight gain side effect is there, so that is why please avoid sulfonylureas. Okay, coming to cost based. Okay, so for example, any of this disease is not there and now you have to decide a drug. So now we'll be seeing the patients okay, economy. Okay, so based on economy, if he's a poor patient, we are going to go for sulfonylureas, glimepiride, okay, or pioglitazone. Okay, so remember, so based on cost the patient can afford, we are going to decide the second drug in dual therapy. Okay, then coming to, if it is more than 9, okay, HbA1c, then we'll see whether he is symptomatic. If there is no symptoms, then we'll go for triple therapy. Okay, we'll add one more drug along with those two dual therapy that I was giving. We'll give a triple drug. If he is symptomatic, some symptoms are there, there are some end organ symptoms are there, then we'll go for insulin. Okay, so that is why for all the patients who are having 7.5 to 9, if a patient comes with 8 HbA1c or I mean sorry 10 HbA1c, so we won't give them insulin directly. We'll tell them, we'll switch them to triple therapy and then we'll give for insulin. Okay, we'll ask whether some symptoms is there or not. So usually 99% of the time patients won't be having any symptoms. Okay, so that is the same thing. That is why we won't start insulin. So suppose this is where we do the insulin therapy, that is when symptoms are there. Okay, now one more thing is, suppose in the first visit itself, if the patient's HbA1c is more than 10 and if the level of glucose RBS level is more than 300, so that is when we'll start insulin plus metformin. At the beginning itself we'll start it. Okay, so this is the thing with respect to management of diabetes. Okay, our target would be goal of the anti-diabetic drug therapy would be always maintain HbA1c less than 7, FBS should be less than 130, then ppbs should be less than 180, and we also should maintain BP and LDL levels. Okay, with respect to anti-diabetic drugs, so it should be always 140/90, less than 140/90, and LDL should be always less than 100. Okay, so please try to maintain this also, or else we'll have to add anti hypertensives and we'll have to add statin drugs and all to reduce LDL. Okay, so this is the thing with respect to anti-diabetic treatment. So these are certain anti-diabetic drugs and their mechanism of action. So this is an extra point, please know this. Okay, please go through this table if you want to know what is the mechanism of action with respect to anti-diabetic drugs. Okay, if you are interested, and please go through this the page. Okay, then coming to insulin, so I'll tell you how to give the insulin. Okay, so with respect to insulin, I told you, right, where all we use insulin. If it is more than 9 and symptomatic patient, we'll give, or else if it is a more than 10 at the first visit itself, we'll give the insulin. Okay, so total dose can be calculated as 0.3 or 0.5 units per kg per day. Okay, so for example, a certain weight is there, we'll multiply into 0.5 or 0.3 based on the weight of the patient per day. That is the total dose. So now for example, I've got certain total dose, that is 8 units of insulin I should give. So now what I'll do is I'll divide them into 50%, that is 4 and 4. Okay, so what I'll do is the 50% of the dose, that is 4 that is 4 units, what I'll do is I'll give it I'll divide it as 3 different doses. Okay, then what I'll do is one dose I'll give in the morning, then the noon, and then the night. Okay, this is called bolus. Okay, so these are called bolus. Whereas the basal dose, the leftover 50% of the dose, I'll give it at the night. Okay, so this is how we'll give the insulin. Okay, so for everyone, this is how we'll give the insulin. Okay, then we'll have to monitor the RBS. Okay, so before giving any insulin, we'll have to monitor the RBS every time and then give the insulin. Okay, so because based on the level of RBS only, we'll try to give the additional dosage. Okay, so if additional dosage is needed, so we'll use something known as sliding scale. Okay, sliding scale, for example 300 will be certain extra dose that should see, this is the main dose that every day that the person should take. Okay, the extra dose if needed, so will be based on the sliding scale. Okay, so sliding scale based on this 300, if it is for 300, it is going to be 2 extra doses, extra units that will give. So this is based on the sliding scale that I'll be giving. Okay, so this is how you can give the insulin. Okay, so the types of insulin will be rapid acting, short acting, intermediate acting, long acting, and ultra long acting. Okay, so this is how the classification of insulins can be done. So rapid acting, immediately it will act. So I'll tell you where it will be used. Okay, just bear for a second. So rapid acting, within 3 to 4, it will stay up to 3 to 4 hours. Lispro is the best example. Okay, now ultra short acting, please remember there was ultra short acting drug which we used to give it for almost 3 days. It was given, that was called degludec. Till date it was there. Okay, we used to use, but now a new drug that is called icodec has come in from India only. Okay, so please remember, in India only it has been invented, so it can stay up to it is a once in a week drug. Okay, so up to 7 to 8 days it can stay. Okay, so once in a week drug, icodec, please remember this. Okay, this is a new update. Okay, then coming to DKA, I was telling, right, diabetic ketoacidosis is a emergency case of diabetes. So DKA management will go like this. Okay, so basically when a DKA patient admits to you, what we'll do is, first thing is we'll take the RBS and then we'll start doing the fluid resuscitation. It should be 20 ml per kg NS over 20 minutes is what we do. Okay, so first thing is fluids is what we are going to give, because we are trying to reduce the ketone bodies that are present in the body. Okay, we are trying to flush it out. Okay, that is what we are targeting. Then after 1 hour is where we'll introduce the insulin. Okay, insulin infusion is done. Okay, what insulin? I told you, right, rapid acting, the Lispro and all will be giving with respect to DKA management. Then we'll go for electrolyte. Basically we'll be taking all the blood samples, right? So in a emergency situation, so here we'll check for electrolyte level also. If needed, we'll be giving bicarbonate and KCl, because to correct the potassium levels also KCl is needed. So that is why KCl and bicarbonate, if needed, based on the electrolyte level, is what we give in the management of DKA patients. Okay, so this is the entire management of diabetes. Okay, I hope you got it. So now moving on to one of the important syndromes before we dive into the adrenal gland pathologies. So one thing I want you guys to know is something known as MEN syndrome. Okay, so multiple endocrine neoplasia syndrome. Okay, so there are three kinds of it. Okay, men 1, men 2, and men 2b. Okay, so basically 2, men 1, men 2. So in 2 there are two subclassifications, that is men 2a and 2b. Okay, so remember it as men 1 is 3p, then men 2 is 2a is 2p 1m, and whereas men 2b is 1p and 2m. Okay, meaning 3p means pituitary adenoma, P, parathyroid adenoma, whereas then pancreatic tumor. Okay, so these are the three things, 3p's. Okay, with respect to men 1. So now minus 1p. Okay, from that, so now remaining is 2p. Okay, so 2a, men 2a will be parathyroid carcinoma, parathyroid adenoma, and pheochromocytoma. Okay, pheochromocytoma is the adrenal gland, adrenal medullary tumor. We'll discuss more about it. Okay, so this is the three things, and 1m should be added, that is medullary thyroid carcinoma. 2p and 1m. Okay, medullary thyroid carcinoma and parathyroid carcinoma. Okay, so coming to 2b, it is going to be again minus 1p and add 2m's. Okay, so medullary thyroid carcinoma and mucosal neuromas. Okay, then the pheochromocytoma already was there, so let it stay. Okay, so this is how you can decide what is the men syndrome, because so there might be questions to decide what type of men syndrome is there. Based on that, we will be deciding what that person is having. So that is why men syndrome is important. Okay, so now we'll move on to adrenal glands. Okay, adrenal glands, the last one we'll be discussing. So in adrenal gland, so let us discuss some of the pathologies that is there, and then we'll go on to the tumor, that is pheochromocytoma. Okay, so the main physiology, let us see. Okay, so first, before physiology, let us see the anatomy of it. So basically adrenal gland has cortex and medulla, right? So cortex is there and medulla is there. Okay, cortex has three different layers. Okay, 1 2 3 different layers is there, cortex. Okay, so each layer will be releasing three different hormones, that is GFR. Okay, so glomerular filtration rate, remember, right? GFR. Okay, so based on GFR, so meaning glomerulosa, fasciculata, and reticularis. Okay, so remember G as G, glucose. Okay, so remember so remember G for glomerulosa. Okay, so GFR. Okay, so now the thing is, the first layer, glomerulosa, will release mineralocorticoids. Okay, the fasciculata will release glucocorticoids, and the reticularis will release androgens. Okay, see, these are the three corticular hormones, whereas medulla will release the catecholamines, that is epinephrine, norepinephrine, meaning adrenaline. Basically adrenal gland is what is the name, right? Adrenal hormones is what the medulla will release from the center. So these are the other three hormones from cortex. Okay, so now let us see the physiology behind it. So what happens? Basically corticotropin releasing hormone will be released from the hypothalamus. It will cause ACTH to release from the parathyroid gland. So pituitary gland. So from pituitary gland, the ACTH comes and it acts on glucocorticoids and androgens. So basically the second and third layer. Okay, so it is not the first layer. Please remember, it is not the first layer the ACTH will act on. It is the second and third layer. Whereas the first layer, that is mineralocorticoid action, that is aldosterone. Remember, right? Aldosterone. Okay, I'll tell you what are the action of all these things. Wait for a second. So aldosterone will be released based on the sodium and potassium levels in our body. Okay, so sodium and potassium levels is what triggers the mineralocorticoid to release. It is not the ACTH. Please remember that. Okay, then coming to the medulla, it is the stress. Okay, the stress in the body is what activates the sympathetic system, and the catecholamines or the adrenal hormones are released. Okay, so this is how the physiology behind all these hormones are. Okay, so this is the basic thing. Okay, so please remember, the glucocorticoids are released increasingly in the morning, and there will be a reduced release in the night. Okay, corticoids is released in this way. Okay, morning there is an increased release, whereas in the midnight there is a reduced release. Because the reason why I want you guys to remember about the cortisol release is, this is where we can test for pathologies. Okay, I'll come back to that. So now let us see. So first thing we'll discuss is about the cortical pathologies, then we'll go for the medullary pathology. Okay, so cortical pathology is, first thing is Cushing's syndrome. Okay, what is Cushing's syndrome? Basically it is increased level of cortisol and androgen levels. That is the two layers, the second two layers. What one is the cortisol, that is glucocorticoids, and the androgens that are increased. Okay, so what happens is, basically the etiologies might be pituitary ACTH might be increased, or the adrenal adenoma would increase it, or if there is a ectopic ACTH that is triggering the adrenal gland. Okay, adrenal cortex basically. So basically Cushing's is where the cortical hormones are increased. Okay, so noted, right? You noted, right? So the mineralocorticoids won't be released by the ACTH surge. So that is why here it is only the glucocorticoids and the androgens that are having the problem. Okay, so how do we investigate? So basically first what we'll do is, we'll first confirm whether it is Cushing's or not, then we'll try to go finally after confirming it is Cushing's disorder, then we'll see what is the etiology behind that, from where is it happening. Okay, so first, how do we confirm the Cushing's? I told you, right? So usually normally cortisol level will be high in the morning and low in the midnight. But see, if in Cushing's, so basically it is an abnormal level, right? So salivary cortisol level will be raised in midnight. So that is how we can confirm that there is a Cushing disorder. Then there will be increased free cortisol in the urine, because too much cortisol is being released in the body, and there is too much excretion also. Okay, then what we'll do is low dose dexamethasone suppression test. Once we give dexamethasone, so basically a corticosteroid, right? So it should give a negative feedback to stop the it should stop, right? So at a lower dose itself, the cortical hormone should be stopped, but it is not giving a negative feedback to it. So this is how we'll confirm the Cushing's. So now that I have confirmed the Cushing's disorder, the patient is having a Cushing disorder, so now I have to decide from where the why is the Cushing's happening. So what we'll do is, we'll check for ACTH levels. Okay, so ACTH levels we'll check. Okay, suppose if it is low, if the ACTH is low, then it is definitely a adrenal cause. Okay, it is not the pituitary ACTH that is being causing this increase in cortical hormone rush. So it is something with respect to adrenal gland itself. So adrenal adenoma might be there, so management will be adrenalectomy. Okay, this is the mainstay of treatment with respect to when there is ACTH low. Suppose now ACTH is high. Okay, so suppose ACTH is high. So now what I do is, high dose dexamethasone I'll do. Okay, I'll try to diminish the ACTH levels. Okay, suppose I give high dose dexamethasone and it reduces its cortisol level. Okay, so that means it is a pituitary gland that was releasing high ACTH level. So that is how I'll decide, oh okay, so this is the pituitary gland that was releasing high ACTH level. So that is why we'll see the pituitary gland, and then we'll do the surgery of pituitary gland. Okay, because this is very dangerous, so we'll have to do the surgery. Okay, so that is how I'll reduce the function of the pituitary gland. Transpenoidal surgery I'll do. Then, for example, I give high dose dexamethasone test. Even then it is not working. The cortisol level is not decreasing. Then it might be a different cause, that will be ectopic release of ACTH. Probably some tumor is there, etc. Okay, see, for example, small cell lung carcinoma has increased level of ACTH. Okay, so that is how we'll treat that particular cause. Okay, so this is the exact management how we do the Cushing's disorder. Okay, so please remember the extra points are: ketoconazole, meteropone can be used as cortisol lowering drugs. Okay, ketoconazole and meteropone can be used as cortisol lowering drugs. Okay, then coming to hyperaldosteronism. So primary hyperaldosteronism or aldosteronism, meaning so the mainly the adrenal gland is affected, the meaning the aldosterone is increased. So in Cushing's it was cortisol and androgens that was increased, but here in hyperaldosteronism it is only the aldosterone that is increased. So this is called Conn's syndrome. There it was Cushing's syndrome, here it is Conn's syndrome. Okay, then here basically aldosterone, what is the main action of it? So sodium should be increased, right? But here the sodium is decreased or normal because of escape mechanism. Okay, so there is a escape mechanism in Con syndrome where the sodium levels will be normal. Okay, so aldosterone had to increase sodium, but in Con syndrome what happens is sodium levels are normal. So please remember that thing. Okay, so now we are done with increased level of cortical hormones. So now let us see the decreased level of cortical hormones, that is adrenal insufficiency. Okay, adrenal insufficiency is what we'll see. Okay, so there are two types of adrenal insufficiency. One is primary, the other one is secondary. So primary, I told you, right, wherever you see primary, it means the gland is involved. So primary meaning adrenal issue is there. Okay, so please note it. In India, if we are having adrenal insufficiency and it is a primary adrenal insufficiency, it is going to be TB, that is most common. Okay, elsewhere it is going to be Addison's. Okay, in western countries and all, it is going to be Addison's disease. This is called Addison's disease. Okay, so primary adrenal issue is there, so it is going to be Addison's. Okay, basically what happens is the cortex is destroyed. So cortex is destroyed meaning the adrenal hormones cannot be released. That is the mainstay. Okay, so that then basically the cortisol level is reduced and aldosterone level is also reduced and the androgen. So see, all the three are involved. Okay, because the entire cortex is destroyed with respect to Addison's disease. Okay, so but ACTH is increased, right? ACTH is because brain is trying to increase this hormone. It doesn't know that the organ has died. Okay, it is trying to increase the ACTH to tell the adrenal gland that please release the hormones, but adrenal gland is dead. Okay, but the brain doesn't know. So that is why ACTH is keep on increasing. Okay, then the secondary cause would be increased steroid usage will cause the negative feedback on pituitary gland and will lead to negative reduced ACTH. So this is how the secondary adrenal insufficiency might happen. Okay, so here we can see the cortisol levels is low, whereas aldosterone levels will be normal and androgens level is normal because ACTH acts, I told you, right, ACTH acts on the glucocorticoids and the androgens, not the mineralocorticoids. Okay, so that is why here it was aldosterone was normal. Okay, the clinical features will be basically hypotension. Suddenly there will be hypotension in certain patients. Recurrent hypotensions will be there. So that is where we can go for the diagnosis of, I mean not the direct diagnosis, we'll try to investigate for adrenal insufficiencies also. Okay, then there might be hyperpigmentation in these people. Reason is ACTH. Okay, adrenocorticotropin hormone will increase the pigmentation in the body. Okay, so please remember, it is not the adrenal hormones, it is the ACTH that increases the hyperpigmentation. This is a previous year question. Please remember that. Okay, now coming to diagnosis, what are the investigation that we do? Here I am doing ACTH stimulation, whereas in Cushing's I did the ACTH levels. I checked the ACTH level and decided what is the etiology. But here I am giving the ACTH and seeing whether there is a release of cortisol or not. Suppose if I give ACTH and cortisol level raises, it is going to be the central cause I'm thinking, right? So it is the the brain is not able to release the cortisol is what comes in. Okay, suppose if I give the ACTH and then still there is no increase in cortisol levels, then it is going to be the primary or secondary cause of adrenal insufficiency is how I can decide. Okay, so this is the basic diagnosis how we do the adrenal insufficiency. The mainstay of treatment is hydrocortisone. Basically cortisol is not there, I am giving external cortisol, so that's it. Hydrocortisone is given and fludrocortisone is also given. Okay, the reason is hydrocortisone how we should give in adrenal insufficiency patients is so basically 15 mg will be given in the morning and then 5 mg and 5 mg, remember, right? So basically we are matching the circadian rhythm. So basically I told you, right, cortisol will be raised in the morning and will be low in the night. So this is what, so cortisol should be raised in the morning, that is 15 mg I'm giving out of total 25 mg. 15 mg I'm giving in the morning and 5 mg is what I'm giving in the afternoon and night. So this is how I can treat adrenal insufficiency along with fludrocortisone, because aldosterone also should be treated with respect to primary adrenal insufficiency. Okay, so this is 0.1 mg that I am giving. So this is all and everything you need to know about the cortical adrenal pathologies. Okay, then now we'll move to one of the important topic, that is congenital adrenal hyperplasia. Okay, so here please remember, if the enzyme is starting from 1, okay, 1 see 11 beta hydroxylase starts from 1 and 17 alpha hydroxylase starts from 1, right? So it is hypertension symptoms that we'll be able to see. If these two enzymes are affected, it is a congenital disorder where these two enzymes will be affected. Okay, if it's starting from 1, it is going to be the hypertension symptoms that we'll be seeing. So that is how you can diagnose what enzyme is affected. Okay, so in the question they'll be giving hypertension. Then coming to ending with 1, so it is going to be, see, 21 is ending with 1, right? I'll come back to 11 also. So please now see, so ending with 1, that is 21 beta hydroxylase if it is affected, then we'll get to see, and this one, okay, ambiguous genitalia, that is virilization will be there. Okay, so in 11 beta also there is 11 the 1 ending, right, ending with 1. Okay, so here also same thing, ambiguous genitalia with hypertension, the patient will be there, and ambiguous genitalia is more prominent in 21 beta hydroxylase. Please remember that. Okay, in question they might give a question like a child with hypertension along with ambiguous genitalia is there, think of 11 beta hydroxylase, whereas they have given salt wasting is there, there is no hypertension, there is hypotension plus ambiguous genitalia, then go for 21 beta hydroxylase in that way. Suppose if they have not given anything about ambiguous genitalia and they have given hypertension, then it is going to be 17 alpha hydroxylase. So that is how you can decide what exactly is happening. Okay, and please remember one more extra edge point, in 11 beta hydroxylase, it is not the 11 beta hydroxylase. See, basically what is happening is, it is all about the production of all these hormones. So all the production of all these hormones is the adrenal corticotropin hormones is what is getting affected if these enzymes are affected. Okay, so if 11 beta is hydroxylase is affected, there might be hypertension. The hypertension is not because of the 11 beta hydroxylase deficiency, it is because of the 11 beta deoxycortisone that is affected. Okay, that is causing the hypertension. Okay, so this is the thing with respect to congenital adrenal hyperplasia. Okay, so that is all with respect to cortical pathologies. So now let us move on to medullary pathology, that is pheochromocytoma. I told you, right, pheochromocytoma is the adrenal medullary carcinoma. Okay, so this develops from the chromaffin cells of the adrenal medulla. Okay, basically there is increased catecholamines. Okay, catecholamines are secreting tumor. Okay, adrenal hormone will be too much. Okay, so basically adrenal hormone is too much, meaning there is increased sympathetic activation. So that is why the triad of palpitation, headache and sweating. If you see palpitation, headache and sweating in a question, please think of pheochromocytoma and Men syndrome. We discussed, right, in Men syndrome is where the pheochromocytoma comes. Men 2, okay, so Men 2, both the Men 2s, Men 2A and Men 2B, both of them have pheochromocytoma, right? So that is how you can come to the judgment of that particular question. Okay, so this is how the pheochromocytoma will present with. Okay, the genetic associations are, that is what, Men 2 syndrome, VHL, then one, that is Warneppel-Lindau, and neurofibromatosis type 1. Okay, so this is the genetic associations of pheochromocytoma. Coming to management, first we'll do the investigation, that is best thing is plasma free metanephrines. Okay, plasma free metanephrines is what we can test, that is a gold standard. Then coming to 24-hour urine metanephrines and catecholamine levels also can be checked. Okay, these are the investigations that we do. And clonidine suppression test, and finally that I've known that this is probably pheochromocytoma, this is probably pheo, then that is when I'll go for CT, MRI and PET scan. Okay, PET scan, remember their name, DOTA-TATE. Okay, so DOTA-TATE is the particular PET scan with respect to pheochromocytoma. Okay. Then coming to the management, the non-surgical management will be MIBG therapy, chemotherapy, and sunitinib. Okay, so this is the non-surgical way that we can treat the pheochromocytoma. Suppose now I'm going to do surgical method, then it is going to be adrenalectomy. So we'll remove the adrenal gland, right? So please note that before doing adrenalectomy, we are going to give alpha blockers first and then beta blockers. Okay, so this is the thing that we are gonna do: alpha blocker first and then beta blockers, because there might be adrenal surge that might happen after adrenal gland has been removed. Okay. Then the high sodium diet should be maintained. Okay, because as we are removing adrenal gland, so basically aldosterone, all this action will be reduced. So aldosterone reduced means there is no sodium reabsorption. So that is why high sodium diet should be given before doing adrenalectomy. So these are all the things with respect to endocrinology. You got it right. All the endocrinological organs we discussed, from pituitary till adrenal gland, all and everything is done. So now we are done with head, neck and face. We'll move on to further topic, that is thorax. Okay, all the head, neck and face, everything is done. We'll now move on to thorax, that is cardiology and pulmonology we'll be discussing. Okay, thank you.